Hello everyone and welcome to the TRSP Webinar Series. My name's Julia Lappin and I am the Clinical Director for the Tertiary Referral Service for Psychosis. I'm a clinician and researcher working as an Associate Professor at UNSW School of Psychiatry with over 20 years experience working clinically and in research aimed at improving outcomes for people living with psychosis. I'd like to begin with an acknowledgement of country and of lived experience. So I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation. I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families, or supporters. So welcome to the Mindgardens Tertiary Referral Service for Psychosis Seminar Series. TRSP is a New South Wales Health funded statewide service which is hosted by South East Sydney Local Health District. And we're grateful to both CESLED and New South Wales Health and to the Mindgardens Neuroscience Network for their ongoing support of TRSP. Before I introduce our speaker, Prof. Sharon Lawn, I'd like just to cover a little bit of housekeeping. You can write your questions in the Q&A, but you can't speak or be seen. And there will be a simple anonymous poll towards the end of the webinar, so please complete it so we know how worthwhile the event was. And finally, I'll introduce Professor Sharon Lawn. Sharon has undertaken a broad range of mental health research at Flinders University, including in smoking cessation, chronic condition self-management, healthcare workforce, health services research, veteran transition and suicide research, coercive practices, mental health peer workforce, and consumer and family experiences within systems of healthcare. Her research uses a broad range of qualitative and mixed methods and focuses on examining the culture of service provision, systems of care, implementation, and service users' experiences of care. Sharon is a former lead mental health commissioner for South Australia and is highly active in mental health lived experience advocacy in Australia and is chair and executive director of Lived Experience Australia, a leading national lived experience advocacy peak organisation. So without further ado and with very warm thanks, I'll hand you over to Sharon.
Thank you, Julia. Thank you, everyone, for joining this webinar. It's a real privilege and pleasure to be talking on this topic again. Just a small correction. I'm the Executive Director for Lived Experience these days because I have a lovely person called Christy Lee Patterson who is a new chair for us. So I'm here in Adelaide on Kaurna land. I've lived here for a long time now, but I was previously born and raised in Victoria, on the just over the river from New South Wales. Okay, so as I was saying to Julia, this is a bit of an ironic topic for me. It's such an intransigent topic. It's not one I've spoken about more recently because I've been busy doing lots of research in other areas. So people coming along now, still talking about the issues, but I'll go into that in a minute. So what I'm hoping that you might get out of today, I've planned this to be a little bit different. It's not going to be a talk about how you actually do the clinical aspects of supporting smoking cessation, etc. That's not my role and expertise. I'm not a clinician any longer. Certainly what I'm hoping is to raise a few new ideas that were probably ideas that I have written a lot about and spoken a lot about in the past, but they still keep getting raised as areas of challenge and interest. So some of the intersections between mental health and smoking cessation, i.e. That these things have to be seen together fundamentally, and some of the insights into the lived experience of smoking and mental health, and I'll explain more about that as well, and learning about how services and health professionals can support people very generally, and hopefully we'll have some good dialogue at the end with some questions. Just a note on language. It's always contentious. So using the words mental illness, mental disorder, mental health challenges, you can't please all the people all the time. And so I apologise in advance if there are any terms that people find challenging. So a bit about me and my path on this smoking issue. So it began for me a long time ago, back in 1998, when I was a fairly new social worker out to community mental health team. In the public staff working area, on the phone to the public trustee, who wasn't available yet again, asking, putting a fax through for the $10 or $15 for yet another packet of cigarettes for a particular client on my caseload. And, dawning on me that day, what am I doing? Why is it that people with mental health issues seem to smoke so much? I resolved that day to find out, and then a couple of psychiatrists on the team said, you should be doing it as a PhD, we'll supervise you. So off I went and did a PhD. I was going to find out about it anyway. And so that was my first entry. What ended up being produced was probably still the most detailed ethnographic account of the culture of smoking in mental health service systems. It was a ripper of a yarn, if anyone's interested. I can't say that my writing back then is the same as it would be now, but that's where it began. Several publications later around the complexities and the myths, the culture, lots of advocacy. I sit here today talking about this again, wondering really how far it's all come and how much today's talk I'll actually be revisiting things that I probably said 20 years ago, which will be ironic. So at the end of all of that activity and an absolute intensity of focus of this smoking cessation area as my area of research focus at the time, I discovered and really came to the conclusion that it was quite a conundrum. The ethical debates were complex. Some things there was no resolution, it seemed. I arrived at a point where, I supported smoke-free policy in inpatient units because of the cultural links. I couldn't see how systems could change, how workforces could change and behaviour could change without some structural supports to do that. I'm not sure that we've made a lot of progress, but anyway, we can talk more about that today. So during a lot of those years, I've had a lot of contact with change agents in services across many countries, usually CNCs, psychiatrists in services, people wanting to know hands-on, how do we actually implement change to support smoking cessation. More recently, I think me and many others have shifted towards a more holistic focus on physical health and mental health. Smoking cessation is hard, and I suspect that's some of the reason why there's been a broader shift. It's also very contentious across the sector as well. Certainly in a lot of my research with staff and with people who are service users, it's a very loaded area, ethically, morally, values, politically. So I think the focus on physical health and mental health has probably arisen out of that tension. And then, obviously in my other life, I've had 22 years of supporting a family member with significant severe mental illness who at different points has smoked heavily, struggled with smoking cessation, and so these things are ongoing lived experience realities for me in my life. So just to give a sense of, I'm conscious that there'll be people on the call who may be, the next generations of mental health professionals and researchers who may not be aware of the work that was done 20 years ago, which is always an ironic thing for a researcher. So what I found essentially from my cultural analysis was that how we fundamentally treat people in our systems of care in the community, the values we hold, the decisions we make, it's all about the consequences of those decisions for service users, workers, etc. So with this issue of smoking and mental health, what was absolutely apparent from that analysis was that cigarettes were being used as a tool for exchange and interactions within what you would call a token economy, an asylum culture. At the time, with most of my research being undertaken at Glenside Hospital, but also in the community and out in the hostels in the community as well, which were also institutions to a large degree. Everywhere I saw, people were heavily reliant on smoking, whether was it explicit or implicit. I had people that I interviewed that said that they started, clinicians that said that they started people on smoking in the ward so they wouldn't abscond, for example. Some settings, long stay settings, where 100% of the patients smoked and 100% of the staff smoked. Quite bizarre, absurd cultural behaviours, which was fascinating. A whole lot was going on, and smoking was just embedded into the clinical management, the cultural management, the social milieu of what was going on in mental health services. Some of you might be saying, well, there's elements of that still there today. So I hope you can see this slide Okay. It's clunky because back when I did this 20 years ago, probably my computer was a completely different type of computer. In fact, I'm not sure that it wasn't even just a straight typewriter, and then the first earlier versions of what a computer was. So one of the things that came out of the data was this idea of, well, this contentious issue around if you take cigarettes away, then there'll be more aggression, more risk of agitation, assault in an inpatient setting. So I aim to draw up a diagram that would try and capture some of the dynamics of what was going on. So at the top you have the patient, the person's aspects, what's going on for them when they arrive, for example, in a locked ward. At the bottom you have the representation of the staff and what actions, decisions, values, whatever going on there. So you have the patient, they're presenting with psychosis, they're agitated, paranoid, etc. There's a heightened likelihood of assault here in the middle. If you recognise nicotine withdrawal, there's a sense of lessening the violence, the risk of violence. You have nicotine withdrawal going on, you have agitation, again, heightened risk of confrontation, basically, between a staff member and a patient on the ward. At the bottom, you've got the enculturated staff who have come with particular value set around whether they're even seeing nicotine addiction as in the mix, or if they're just seeing the mental health focus. So they may recognise the psychosis, recognise the nicotine withdrawal, do that combination of both, and the agitation lessens because they're working in a clinically sound way to recognise that both are at play here. A failure to diagnose and recognise the nicotine withdrawal, increasing agitation, getting angsty with people because they're, labelling it as something else, having no cigarette supply, no NRT, no clinical management process. The actual ward environment itself comes into play around boredom, other elements. So it's trying to just show how this can all get something else. It can get out of hand to be something much more than it is, purely by the failure of not putting mental health symptoms, nicotine withdrawal issues, and recognising that they have to be considered in partnership. So that was more than 20 years ago, formulating that sort of idea around this area. Some of the other things that happened at that time as part of the thesis were a whole lot of interviews, a whole lot of observation. But I've got a few just very choice quotes, and I think some of them still resonate today. I still remember them vividly. So this was nearly 25 years ago that these interviews were done. So Mark is a person with a diagnosis of schizophrenia, not his real name. I think he captures the essence of the elevation of the importance that cigarettes were playing in his life, and how there was no support for him to actually do anything about it. I think when he says it was it was just a smoke, I would have done anything for one at the time. So the next one from Jean, who also described a very visual sort of physicalness of the cigarette. So she also described the breathing in of the smoke and the soothingness of that, and how she was using it to actually mediate her mental health symptoms. So I don't have to think. It gives me time out. If I had more time to think, I'd probably get depressed. Just knowing they're there is enough to calm me, but then I run out and I panic. So this is seriously interacting with people's mental health conditions, I guess, is what I'm trying to get across. Some examples from the staff at the time. So Grace, who was a senior nurse, so people picking up on that there's not much to do. The therapy seems to be smoking, essentially. Let's wait and see the medication work. I'm sure you can probably relate to that. The only normal thing to do at the time was to smoke. So even the staff are recognising these things. Jane, the social worker, reflecting on their practice and empathising with this smoking, this modelling behaviour. And part of working with really difficult clients is trying to find an entry point where you can develop rapport. And what was more easy than sitting around with them and having a smoke. And then John, who again was a consultant, very influential in the team overall, so in a leading influence. In my heart of hearts with patients with schizophrenia, I feel like they haven't got much left for them. So good luck to them. If they want to smoke, let them. So that was the prevailing value set at the time. Let's check my... So as you can imagine, there was lots of thinking about this absolute complex mess of culture and clinical and how do you make inroads here? So, looking to things like the Prochaska and De Clementi stages of change, which is pervasive, in the addictions area, pervasive in the health area still. Where does it actually get us? Does it actually help in this situation? I sort of came to the conclusion at the time that it doesn't, because most of the people that I was seeing were in the pre-contemplation stage, and I actually took offence at the time to this idea of people having no intention of changing their behaviour being the broad definition of pre-contemplation, because what I was seeing is people very, very trapped in addiction, people who wanted to change but just felt they couldn't. I think the advocacy was well and truly starting then. And the other thing around this, there's been a range of criticism and response. It serves a purpose to help understand things at a concrete level, but it doesn't capture the complexity of how people move back and forward. People can move back and forward in the same hour, in the same day, in the same week, across the stages of change. Let's check the time. So many pre-contemplators are not choosing their stance. Many people do want to quit smoking. It's not a health literacy issue. I didn't meet anyone that didn't know what the harms of smoking were. I haven't met anyone with mental illness that didn't ultimately want to give up smoking. I'm sure there may be some out there, but I haven't met them yet. Many people I talked to that just felt that they couldn't succeed. A number of those people were just scared of becoming unwell. This idea of the services being it's their only pleasure was pervasive. But how did it get to that? You know, what is it that services were or were not doing that it was an easy endpoint to reach? Well, just let them. So obviously the human rights issue come into the mix, as you can see. I haven't got time today to unpack the debates around this, but you can start to see that it's incredibly value laden and gets very complicated by the value ladenness. The rights issues add to that complexity. Issues of paternalism in clinical care. You know, how dare we tell people whether they should smoke or not, et cetera, et cetera. But I can certainly tell you, you know, one particular observation out in a community hostel boarding house, 7 o'clock on a Sunday morning, watching the residents all sit out, all smoking, and one man walking around basically bartering and begging for cigarettes. Yeah, I didn't see him choosing that at the time. So some of the areas of knowledge that I've sort of accumulated during that time of thinking and writing about all this stuff. So things that hopefully some of them now resolved, some of them clear, some of them that we know the knowledge. So, you know, we know the harms of environmental tobacco smoke. It's well recognised. The issues of smoking rooms and smoking in outside areas doesn't actually eliminate the exposure to ETS. Well established, and the compliance issues with designated areas in totally smoke-free areas. There's a sense that it is the only way to protect patients and staff from ETS ultimately. The other thing is this may or may not be, I don't think people are even talking about it really at the moment, but they were when all of this was being talked about and debated around partial and total smoke-free policy. So there was absolutely a sense that partial smoke-free policy, what I mean by that is that granting leave, for example, for people to go out to smoke, etc. Having designated places. All of these things open up cans of worms for people who can and can't leave the ward, issues of equity, and what that, you know, some of those layers create then is conflict, because, you know, fair go. If I'm a person who's a patient in a ward and I see everyone else going out for a smoke and I'm not allowed to, then I'm thinking that's pretty unfair and I'm going to get annoyed about that. So, yeah, complex. So partial creates more problems than it's worth, was the conclusion that I came to. Another area of knowledge that we absolutely know about is the issue around physical health, comorbidity, and the impacts of all of that on smoking. You know, we still don't have a clear number of, you know, is it 20 years, is it 15 years? We just know that it's less. And obviously the work that Equally Well's been doing more recently is a real testament to that. The latest death data report that came out 2 or 3 months ago is incredibly telling, I think. Smoking impacts on multiple social determinants of health. We know basically it keeps people poor, it jeopardises housing tenure, you know, many other social determinants. It's discriminatory, it's stigmatising for people, as increasing numbers of people are quitting smoking. People with mental illness we know who stop smoking, they actually have better long-term mental health as well as physical health. The next area is the clinical management of addiction. The old pearl of the Kantian self-medication theory that was prevalent 25 years ago as a very strong theory around smoking, you know, has been questioned by a number of people. More recently by Mansella and others. Is this all just an issue of good clinical practice? Back to that idea of that diagram I showed you. Whenever you are working with people who have serious mental illness, who are also smoking, you must look at both things in unison. They are completely connected with each other. NRT does work if used properly, consistently, augmented with CBT. There's evidence. You know, I'm not going to go into the layers of this today. You can all read the fantastic Mindgardens resource on tobacco treatment. Everything's there. All the current evidence knowledge has been captured in that. The next area is this idea of which, you know, I'm not sure at the moment if staff still hold some of these views out there. I'm sure there are some that do, that people with mental illness can't give up smoking or they just don't want to. We found 20 years ago through research, Maxie Ashton led research with 1,000 people surveyed. Yes, they do actually. They do want to give up smoking, and people can. The systems need to be connected up. People resume smoking upon discharge if they've stopped smoking in inpatient units. These things are just logical, aren't they? Why would you set someone up for failure? We don't put people in alcohol detox and then throw them back out into environments where everyone around them is drinking alcohol or their social circumstances are reinforcing that, and not expect them to relapse into alcohol use. So why would smoking be any different? There's a really interesting study back again, 2003, 2004, 20 years ago, in the New South Wales Forensic Unit, where we actually looked at this. Angela Hare's paper is out there if people are interested. Overwhelmingly, people said it was easier to stop smoking in a setting that was smoke-free. Many, it was the first time that they'd given the opportunity to use NRT. There was follow-through during that time for people post moving on to wherever their next stop was or out into the community. it works when you put all the pieces together. Another area of knowledge was around boredom. I think this one is still relevant absolutely today, as I see more and more inpatient units that don't have a funded OT program because it's seen as an add-on, for example. Other things that are seen as add-ons and not essential. So culture of smoking reported back then as absolutely a reason for an uptake of smoking in settings that were just barren wastelands of boredom, essentially is how I described it. And just relapsing because everyone else was doing it and there was just nothing else to do. And then the last area is around the rights and choice issues, and there's some very strong sides taken on the rights issue. The WHO and United Nations, the right to health, positive right to health. There are lots of arguments there. Sorry, I'm clicking again. And the inconsistency that's applied with other activities. So how we dismiss some things, but we say other things are important. So, I remember back then, we don't let people bring a six-pack into the ward with them and say, well, they have an alcohol dependence, so they need to use it, essentially. Okay, so just a little bit on, can smoke-free policy have positive impacts? Lots of research done around the time. Paula Y, W-Y-E, it's a surname, did a lot of research at the time in New South Wales and nationally. Yes, staff and patient physical wellbeing does improve. Staff and patients' perceptions of their capacity to quit smoking does improve and expand. Staff smoking rates decline in those environments. The care is actually enhanced because the people are less bored, more engaged in the actual activities if they're available on the ward. And ironically, the staff skill sets, the interpersonal skills, the therapeutic skills improve because they're not just using cigarettes and the smoking area and they're actually getting engaged in the role. Nicotine dependence is addressed, the patient's quality of life improves. And interestingly, a number of studies found that increased aggression, that concern was unfounded. In fact, it went down in a number of studies reported that it went down. The leaving against medical advice, again, unfounded. Rates of seclusion, again, unfounded. So you can see there are a lot of myths, a lot of assumptions. I suspect some of those assumptions are still holding today. So for me, this has all felt a bit like, as you can imagine, this has all felt a bit like Groundhog Day, given I wrote all about this 25 years ago, studied, and people are still studying it, discovering, this thing about culture and assumptions and values, issues behind why we do or fail to act on this issue. So I've taken this out from a very recent paper where I actually saw some of my words I'd written 20 plus years ago. I won't read it out, I'll let you read that. but you can see the issues of boredom are there. The spectre of possible violence, concerns that were being raised by staff decades ago are still being raised by staff. So this was a New Zealand study. Susanna Every Palmer was one of the lead researchers, who some of you may or may not know. And then the conclusion of this very recent paper, which is the same conclusions that were being drawn 20 years ago. Psychiatric boards remain overlooked. Hospital smoke-free policies are inconsistently applied or ignored. Blanket applications of generic policy are unlikely to succeed. Solutions may include myth-busting, which we did. Education for service users and staff, which has absolutely been done, needs to be done. Local champions, strong management support, unlike that psychiatrist who held that particular view of defeatism. Consistent application of NRT support, etc. Smoking cessation would be supported by better designed facilities with more options for alleviating boredom, expressing autonomy, facilitating social connections, and reducing distress. So what's change? What do we need to do? Would be where I sit with this one. There's a lot on what makes facilities successful. Just check my time. Yeah, you can read about this. There's plenty in papers I've written and others have written about it. It's all about training, collaboration, helping staff put these things together, asking about smoking, incorporating nicotine withdrawal into clinical care, identifying people who may particularly struggle, and doing the clinical role with those people consistently, intensively, etc. Okay. So there's a whole lot of cycles of undoing cessation efforts. So I'm moving now on to what I've taken away from what I've learned personally from living with someone who struggles and has struggled with this stuff every day. Huge role of self-worth, playing havoc with symptom management and playing havoc with withdrawal. These things become the one thing. They chase each other hour by hour through a day for a person. They are just so embedded. The other thing that I've certainly presented on in the past and know that a lot of the smoking cessation advice around set a quit date, set goals. There's a lot of abstract thinking in this. But for someone perhaps who has a psychotic illness, who really is just trying to manage the symptoms that are present in front of them at that moment, their ability to recall the abstract, it's just not there. When you're anxious, distressed, it's a big ask to call to mind the things that just roll off the tongue so easily from someone who's giving their good advice about smoking cessation. It's harder done, is what I'm saying. So I thought this last quote really struck me at the time because it explained what I was observing. So instead of turning down a path of control-based strategies that may paradoxically increase the negative content or the anxiety of the person, individuals who employ mindfulness strategies learn to notice their experience, distance themselves from the content, and turn away from judging the thought and themselves for having it. So this cycle of, if you imagine a smoker sitting there getting anxious, smoking more because they're anxious, knowing that it's harming, they're really concerned about their physical health. The concern, for the logical thing to expect would be, I'm concerned about something, so I'm going to stop doing that behaviour. No, the opposite becomes the case, where more anxiety means they're smoking more. And so I'm sure that some of you will have seen this over and over again for people. Again, it's an irony, but it has to be recognised because it gets in the way of the person's own efforts to quit smoking when they really do want to. So anxiety just breeds anxiety. And then my last slide is a little bit, just some reflections from thinking about what I'd say today. Smoking shapes and shifts with the rhythm of mental health symptoms every day. So it's what I might sort of be feeling about my resolve to be strong an hour ago compared to how I'm feeling now can change. How I wake up today, how I wake up tomorrow may be very different, purely because the rhythm of psychosis can go up and down from day to day. Absolutely, caffeine, sleep, stress, PRN use, alcohol, those cycles that impact more than you'd think. They absolutely feed each other. The Mindgardens guidance talks very briefly about caffeine, alcohol. What I'd say is talk more to people about how they're using these, what's occurring in across these areas as well, because again, they become embedded. They absolutely become embedded with the whole process of smoking and managing mental health. Everything is absolutely temporal, as you can probably imagine from what I've said already. For the person, it's absolutely in the moment, which means that, smoking cessation efforts where you're having to think, further in time, by next week I'll be here, by 2 weeks' time I'll be here. No, it's in the moment. So bring back the support to be more temporal as well, so people don't fail. NRT not sufficient on its own. People do want a magic pill, whether that's just because of where they're at, cognition, whatever, being human. We all want a magic pill. This other issue around, if a GP prescribes NRT or a doctor suggests that, sending them off, say, come back in 2 weeks' time and tell me how you went, completely insufficient. I think anyone who's sitting in front of a young person with early psychosis, please, that's your big opportunity. Prevention is so much better. I know my family member regrets having ever started smoking, which they did as a young person struggling with psychosis. Absolutely. And the profound impacts on quality of life for the person. There are impacts for everyone around them as well. And I'll probably leave it there. Okay. There's a whole lot of references at the end of this. I won't go into those. I'll switch over to them. And now Julia's going to talk, and I've got some slides, Julia, haven't I?
Yes.
There you go. There's
So
the
let me
lovely.
thank you first of all, Sharon, for a great talk, and just so wonderful to hear about your insights over these very many years. And we'll come back and talk to you in just a minute. So I can see that people are already starting to enter their questions into the Q&A. So thank you for those, and please take this opportunity to pop a few questions in for Sharon. And meantime, I will tell you about our final webinar for 2024, which I will give, and that's really going into what is it that TRSP does. And if you want a quick preview of that talk, I'm giving a different version of it Wednesday of next week. Thanks, Sharon. Then we'll just move to how you can contact our service should you need to. This is the email link here. And we'd be delighted to have any questions about our webinars or indeed about referral inquiries. And here's some more information about Mindgardens. So thanks. We'll stop screen sharing now, and we'll move to the gallery. Sharon, thanks again for a great talk. You've had many years experience in this topic, and I think from my own observations, I would say that sadly, you're probably right that things haven't tremendously changed since those years when you were conducting the research around smoking. And we do see these cultures persisting in mental health environments. I think it's just tremendously helpful to have the opportunity to have thinking time to process, to think about some of these big concepts that you talk about, you know, and some of these attitudes that I've certainly heard very well-intentioned clinicians saying over the years, you know, these people have nothing else, surely we can let them smoke. These are pervasive ideas. So I don't know if you want to comment on that. You probably feel that you've sort of done that already, but it did really resonate for me what you were saying in the talk.
Yeah. I guess, you know, I heard so much about the cultural stuff that personally I arrived at that, you know, anything where, because organisations and service, it's very hard because everything's temporal for staff as well in a working day. And so as soon as you get, you have a policy, and as soon, or you have a process, a procedure that that people are operationalising. Imagine like in a factory where, you know, start here and then you go to there. As soon as there's some deviation or break, that means that it all gets a bit ambiguous. Then the whole thing gets undone. And every time there's ambiguity, like, well, you know, come out with me and we can go and have a cigarette. We'll get you here. Like, people just stop, you know, they stop following their own sort of procedures, if that makes sense. And it becomes fraught and fruitless. And then, you know, you get then staff start arguing with each other and holding different ground and, you know, becoming despondent with the very processes that are meant to then help them do their, you know, if you get what I mean, it becomes untenable.
It does, it
everyone
becomes
concerned.
fraught, and it becomes, people take positions then, I know.
Yeah, and it becomes something completely other than what everyone intended.
Yes.
And it becomes completely removed from it even being considered a clinical issue.
Yes.
And it completely feeds into the cultural stuff and ignored. So
Important
it's a really hard
to
one.
keep talking about it. So I've got some really interesting questions from some of the audience, and I can tell by the questions that many of these people are clinicians, and these are real life issues for us all. So let's just have a look at the first question. Sharon, do you have an opinion on daily staff escorted leave for smoking being used as a behavioural management strategy for long stay rehab consumers?
Well, it's like what we just said, like the patient group are, they're not silly either. It becomes punitive, and they know, people know when
Yes.
control, coercion in its explicit and implicit forms are being used against them. And so, yeah, and they're not siloed from each other. So they see how staff are interacting with other patients on the wards. Well, he's getting some of that. Why can't I?
Yes. Yes.
So what it does, you just open up more cans of worms for having to manage conflict and ambiguity.
Yeah.
Yeah, it's really hard. I absolutely understand. We had someone in the South Australian system for many years called the $6 million man, who had two staff who just stayed with him 24 hours a day, and he was significant brain injury, etc., from whatever. And yes, he was escorted out for smoking, but it was a very particular situation. Like, where do we draw lines? Where do we say we're not going to do whatever we can clinically to support someone with their, what is an addiction here? Yeah.
Yeah. So
It's a hard one.
a related question, what advice would you give to clinicians working in a space where advocating against staff physically supporting consumers to have leave for smoking is seen as restrictive and punitive? As we need to be realistic, we're not going to make them quit. This is this idea again, which is very current and seemed to be also 20 years ago.
Yeah, yeah. So, obviously establishing a plan around having a smoke-free facility really needs everyone involved who will be impacted by it. There's a whole lot of planning, a whole lot of preparation, commitment, leadership, not just at the start but throughout, problem-solving support. This is an all-in effort. So, if this process of, I can well imagine this happens, and it needs to happen in some circumstances as part of doing that. It's not something you can just say one day we're going to be smoke-free and the next day we're, the day before we weren't. It takes a really solid change effort. So I can absolutely relate to, as I could then relate to the staff and the challenges as much as to the concerns that patients on those settings had.
And Sharon, Sarah has sort of talked about a related point, this idea of addressing boredom. Part of any change strategy would really need to be thinking big picture. If boredom's one of the underlying contributors to people's desire to smoke, how can we address boredom for consumers in the ward who are trying to manage their nicotine dependence?
Yeah. So the other things about, boredom is also about distraction, and one of the tenets of smoking cessation is around strategies for delay, and and the idea of cutting down. A lot of people I know who are smokers with mental health, it's about the cost and trying to keep the number of cigarettes that they're smoking down, not necessarily quitting, but trying to maintain a low number. And so, you'll meet people who will fill up their day. They'll have a whole range of strategies. You know, I'll leave my packet at home when I go down to the shops, because I know as soon as I step out the supermarket door, I'll want to grab my packet and light up a smoke. So that'll be one less smoke that I have in my.
Yes.
Yeah.
So you're an advocate of cutting down as well as hard quitting, Sharon. It's really just
I
trying
think
to reduce
it's
harm.
entirely up to the person. If
Yeah.
they, you know, a lot of people have, you know, it's about experiencing and learning for themselves the strategies that people have, and seeing the evidence that they can do it. You know, and for some people, that's the process of cutting down and learning more about. You know, when are my times when I'm more likely to, what can I do? What alternatives do I have? It's a whole lot of things. It's complex, giving up smoking.
Yes.
Yeah. So it's a
Sharon,
boredom, you know, the boredom issue in particular on the ward, you know, I see increasingly that inpatient units are places where people are shorter stays. There's nothing to do other than, you know, the clinical actually treatment with medications, the perhaps interaction with other patients for that brief period, and then out. Yeah, boredom is a big issue
big
for
issue.
people. Yeah.
Thanks, Sharon. Unfortunately, despite us having quite a number of other questions, we've run out of time for this afternoon, Sharon. But with your permission, we will send you the remaining questions and see if you could pen a short answer, and then we'll circulate Sharon's responses to the audience in an email over the next fortnight. And Sharon's webinar will be available on the TRSP website. So Sharon, many, many thanks again for a wonderful and reflective talk, and thanks for all that you've done in this space. All the best.
Good luck, everyone.